Okay, good afternoon. Welcome back to CAT Lab number 4 after this challenge chip case that we did with Dr. Lev on room number 1. On my right, Dr. Carlos Fava, Silvina, Erika, who is our technician, and Claudio, Alex, as our nurse, and Nora, nurse, and Gabriel, who is a technician from Medtronic. I always forgot the names of everybody. So Dr. Mukersel, and who is here, Herman on the anesthesia. So there's something wrong on me about the names. This is, we have prepared a very interesting case, I think, to finish the session today. This is a 4th episode of MyStream 360. So we can see the slides. The first one, perfect. Next one. So she's an old lady, 82 years old, presenting with angina, dyspnea. She has a history of hypertension, dyslipidemia, a smoker. She also suffered from breast cancer. She was operated on and she received also radiotherapy on the chest. She also suffered from a carotid cavernous fistula associated with ophthalmic vein thrombosis, and that's why she received during some time oral anticoagulation. But any further treatment was necessary regarding that, but she is under follow-up with our neuroradiologist here. Next. So this is AGC, nothing special about that. The PQ is normal, some left deviation of the QRS axis. Next. So the blood test is quite normal renal function. Body mass index is 22. The echo Doppler showed a severe aortic stenosis with preserved left ventricular ejection fraction, 73, with gradients of 66 and 42, with an area of 0.6 square centimeters. According to the frailty evaluation by our team, she is not a frailty. She is not futile for this procedure. Next. So this is the regular angio that we always perform, as I told you before. She also has some, vertebroplastia done there. This is the find that you can observe on the radioscopy there. This dark mark there on the lower part of the right coronary artery. Next. This is the left coronary artery, which is a vegan artery with huge vessels without any significant lesions, except probably some kind of breach on the middle segment of the LAD. Next. So this is a left caudal view, showing that left main is perfect, no lesion on the ostium. The cranial view with similar findings, and once again, this not occlusive breach. Next. So according to the core lab evaluation on the CT scan, she has small annulus, 17 by 23, with a mean diameter of 20, with a perimeter area of 64, with an area of 320. So the coronary ostium height are 11 in this measurement for the left, and 11 something for the right. That's something that we are going to discuss later on. This is the sinus, which are also quite smaller, less than 30, 26 and 27. Next, the LVOT is also small. This is my evaluation here, or the evaluation that we always have in our team on the CT scan of every patient. Here in our findings, we can describe a significant calcification on the sinotemporal junction, as you observe, on the upper part of the left ostium, and also on the right. And below of the slide, we have measured the height of the coronary arteries, and right coronary artery is not that high as 11, actually it's lower than 10. So it's at least on middle or high risk for coronary obstruction, because also the VTC distance that I calculated is also borderline, 3.8. So remember that 4 is okay, below 4 is high risk for coronary occlusion. The leaflets of the right is calcified, it's long, another issue to be considered about the protection of this coronary ostium. Next. This is the calcification on the stenotubular junction with this also small diameter, 21. This is important for the valve selection and also for the procedural, because we have to pull back the right catheter. Carlos, remember
Yes,
that?
yes.
Before final deployment of the valve, because sometimes you have difficulties to retrieve the pigtail. Next. Here are the measurements done at the core lab, once again, 11 and 11. Next. And this is our angio-CT finding. Next. Next. And this is what I already told you, the BTC distance that I measured for the left and from the right, because you could ask me why not to protect the left, because it's also at 11 millimeters. And the right is a discussion between 11 and 9, which is my personal measurements. But here the BTC distance for the right is smaller. And as you can observe there, the distance from the estimated landing zone of the valve in comparison with the ostium of the left main is bigger. So that's why I think we are not risking the left, but yes, in a way we are, challenging or risking the right coronary ostium. Next. So this is the ascending aorta, also small aorta, significant calcification, but not that much. So that's why we have decided to go with direct implantation, not to pre-dilatation. Do you agree, Carlos, on that?
Yes,
Okay,
definitely.
Okay, perfect. Because this calcium is deep, I think it's not going to interfere with the valve dilatation and also not with the deployment. Next. So this is the aorta, not significant angulation, but not too low too. This is 50 degrees angulation according between the aortic annulus and the left ventricle. Next, no significant calcium on ascending aorta and also the aortic arc. Hopefully the vascular access are okay, a little bit of tortuosity on the right, but not that much, not too much calcium there. So maybe we can use the new technique that we are using is to use only one proglide. And then if we have bleeding, we can introduce an 8 French angioseal. Anyway, we are still doing for every single case the crossover for protection, especially when we are alive. Next. This is the aorta, and this is the diameters, good diameters. I think very good vascular access for this evolute implantation. Next. This is working projection. The LO could be LO 9 and caudal 8. And for the right, near to the cusp overlap is 5 right and caudal 26. But we have a different, that this is the angulation where we have a perfect cusp overlap view, which is right angulation 16 and caudal angulation of 35, 25. Okay, yeah. Perfect. So it's going to be in a very high caudal angulation. It's not going to be so comfortable for working. Next. So at the end, she's an octogenarian with severe coronary artery disease and aortic stenosis. Although the STS score is low due to the age and previous chest radiation, on the heart team discussion, the LAD PCI was suggesting and stage TAVI as a second procedure is where we are. Next. For some reason, we escaped the slide of the coronary angiography, but we can see probably in the next. So we did a LAD PCI by radial approach, and now we are prepared for femoral approach for this TAVI implantation with also right coronary ostium protection. For that reason, Dr. Carlos Fava has prepared radial approach that we'll show you later on. Next. Next. So this is the angio, where she has a moderate to severe lesion distally to this huge diagonal branch. We did a pre-dilatation and then a very short stent implantation. Next is something that probably we can discuss, but the patient has angina and his referral wanted that this lesion be treated. So we discuss about that. And this is the reason why we agree on doing that. And now we are here. So this is so the radial approach that Dr. Fava has already prepared, and on her left arm. Yes, if you turn to the right, we have a 6 French here, where we will introduce the right coronary artery guiding. We have femoral access here, arterial and venous. We are going to do crossover. And I will ask the team here that if it's not too much noisy, we can increase the conditioned air, because I am suffering hot, because this crab that was prepared for me is too close. See, yeah, I know. Perfect. So we usually try to cross over with the pigtail. If something is not working, we prepare a seam as we did in the previous. Let me reshape the wire first, and then prepare this vaso de cuello curva 2. A seam 2. Why would we change the catheter instead of the wire? Yeah, no, it's enough. Ya está. This reshape of the wire facilitate the crossover. Closing the loop of the wire is a good choice, not to waste too much devices. So our salary can be increased. So I don't know if we have echo here for Herman, will you have echo? No. Okay. Well, I think we can prepare. Is it okay there?
¿Lo tenéis ahí? No, no está.
Is there? No, ¿lo tenés acá? No.
Sí, sí, lo tengo que prender.
It's okay. It's okay. It's okay. Let's go with the conventional way. Test, Carlitos. Okay.
Sí.
Okay, here, aren't you guided? Here. Perfect. Correct. So here we have to make a small cut of the skin. We have to make a divulsion of the subcutaneous tissue to facilitate the prog-like thread movements. Although she is a very small lady, not too big, and so everything is gonna be easier, I guess, or hopefully. So now we are going to complete the heparinization, and then I'm gonna cross with the 018 wire. No. Bring the, okay, más aquí. La ingle. Let's go. Okay. We are on SFA. We are going as deep as we can. Where we find some resistance, this is our place for parking. We retrieve the catheter, correct? Okay, leave the wire that we are using for protection and also for control of the closing, of the vascular closure, sorry. The other issue that probably we can discuss in this patient is if we should have to pace her for the delivery of the valve, or I mean to introduce a pacemaker, or just to pace with the wire. Well, I do crossover very easily, but not that easy always. So we have chosen, according with the AKG that I showed to you, that is probably good patient for being pacing with the wire, with the confida wire that we are going to use. So if we have some problem, if we have some conduction disturbances during or after the procedure, we will change and we can put the pacemaker. So here we are. We are closing the prog line. is okay. And now we have the thread. Now Carlos has the unplugged wire and Silvina has already prepared the 14 sheath. ¿Tenés el?
Sí, perdón.
Okay, date vuelta, Silvina. And now I need the right coronary artery guiding. 1014 extra support. O el guiding de derecha y la extra support. Okay. We leave the unplugged wire there and then we will introduce the pigtail, but first I will position in the guiding on the right coronary artery. Or probably we can cross. No, let's go with this. Okay. Let's see here. Hopefully we don't have any problem to cross here. Okay. Ahora vamos a ir a la oblicua izquierda. Vamos a necesitar llave 3 vías. No, acá tenemos. Ok.
Sí, espérate.
Yes. Okay. No. Dale, dale. Okay. I don't like to work from the left side because you receive a lot of radiation test, Silvina. Don't know how easy it's gonna be to engage the right test. Right is normal. We will leave an extra support wire there. And remember, as always, we usually do this kind of maneuver. We will put a guide extension inside. In case we have a problem, we will introduce the stent through this guide extension. So with this maneuver, we prevent to destroy the stent if it is not necessary. We are in a poor country. We have to take care of the resources. Always putting patients first, but trying to be as cheap as we can. So give me the guide extension. But I will leave you there. We'll leave it there. I will keep you here. I will leave the guide extension there. Sorry for destroying the English. So Dr. Andres is again behind the screen. So Andres, if you have questions from the audience, don't hesitate to translate to me. Translate to transfer to me. Okay, let's go with the pigtail. No questions so far. I would like to invite to everybody to comment or to make questions, how you do it, how you observe this procedure are done in your town, in your hospital, your country, wherever you are. Like very clean hands while working. Hold it, Silvina. Okay, now we will try to cross with our regular maneuver with the sheet wire. If we have problems, we will try with the unplugged catheter and then to change with another, with the pigtail, sorry. So if you point, give me some zoom. You point out on the middle part of the aorta is sometimes is very easily to cross. Remember, keep in mind the oblique quadrature, right oblique view to advance. On this view, I try to be sure that the wire is distal enough, not entangled with the wires, excuse me, the cords of the mitral valve. So I think this position, it's okay. Now I'm going to positioning the pigtail. For control during delivery. So this is the gradient. Let me flash first. You can measure this gradient and then we will, yeah, we will measure again with the pigtail because probably the guiding is a little bit, I mean, in the ostium. So we will have a better gradient. Okay. You have something to put here?
Yes.
Clean before starting? Okay. So that's what's talking about difficulties to positioning and also probably for retrieving the pigtail when you have significant calcification on the sinotubular junction. So now that everything is in place, we have a clean area. We can pull the wire. We can close it. We can measure the gradient. Give me a second, flash. Flash. Okay. Now you can measure the gradient, which is like 80. Okay. Perfect. Vamos a la proyección de trabajo. We will do the injection, the test first. Okay. Okay, I think it's a good positioning there. And you see that the right coronary ostium on the middle part of the monitor is not that high. So I think it's important to protect it. So we will shape the wire while Tim is preparing the valve until the valve is ready. When the valve is ready, we will check it. We will do something here. Okay, where is the pro light? Give me the syringe with water and the needle to put here for pacing. Yeah. No, I actually protect left main when it's below 10. Below 10 is I will protect every single case. If it is like here, intermediate, and you have a VTC distance estimation of less than 4, for sure should be protected. If you have less than 10 and any, I mean, between 4 and 6, anyway, I will protect when we are doing valve in valve. But in this case, I will not protect it. Hopefully I am right, because if I am wrong, we will be in problems. When I protect it, like the case we did last week, which was an intermediate case, but the left main was below 10, or at the border of 10 or borderline, we decided to protect. Let me go to the AP view. Let me ask Dr. Mukarsel, have you checked the echo?
Yes, I have already checked the echo.
Describe? Yeah.
Yes, we have. Let's take a look again. Just a second, if you want to.
Okay, we have plenty of time, so
Okay.
I think it's okay to. We always check the echo in advance to be sure we don't have pericardial effusion before the procedure, like the case we did yesterday. There was a lady, a very sick lady, and she had pericardial effusion. So it was important for us because we were not that worried. after the procedure because this pericardial effusion was kept in the
So-
similar amount. I mean, after the procedure.
So as the echo shows, we have normal LV function and no effusion at all.
Okay, that's great. So let's check the valve in advance. We are protecting the patient's face, just not to touch, and also for identity to keep the procedure and following the HIPAA. You can observe there the probably here better. Corre un poquito para acá, para allá. Sorry. Here is better. You can rotate now, and you have here perfect the two paddles. So now we are going to introduce the wire and we are going to the working position. I am still thinking on the case, on the last case we did in the other room, such a complex patient. Carlos, please hold me
Yes.
the sheath. Dr. Fava is gonna hold the sheath. Wire is distal enough on the apex. The ventricle, the left ventricle is small. That's why I always reshape the wires to give the smaller shape as I can. Now, Dr. Carlos is gonna retrieve the sheath, keeping the wire, please don't. Okay, and now we are going with the direct implantation. So pay attention to the blood pressure. It's a little bit low now, probably due to some extrasystoles. It was easy to go. Hopefully we don't move any catheter too much. Oh, let me do something before. Let's go to la vista izquierda. Y tenés problemas, sacate el
No.
micrófono. So this is the moment where I have to engage the right very well. And I had to advance the guide extension distal enough, just in case we have to, let me. So I don't have a good alignment with the ostium. And the catheter doesn't have a good shape. But give me coronary view. Perfect. So probably we can use the balloon to position him better. Dame un balón cualquiera.
Sí.
Apúrate. To have better support and to positioning the guide extension a little bit distally. I know I'm going to produce a little bit ischemia, but it's better because during deployment, if we have to retrieve the valve, you have repositioning, we might lose the position and everything, all our work will be lost. So I am advancing a balloon distal enough to have a better support and probably advance the axilla a little. In this case, it's a Medtronic device. It's not that easy. Yeah? Let me go distally with the balloon. If not, we have to accept that this is the best position we can reach. Although I have an extra support wire, now it's much, much better. Okay. Leave it everything there. Let's go with let's go a la posición de trabajo. Subirle un poquito la presión, Jaime. No, no, Jaime. Okay, Germán. The wire is better. Let's go now. And we can start deployment there. Sorry, no lo vamos a probar. Raspaste aquí. Okay, I will let you know. That's the test. Okay, start, Carlos. Let's go. 120. 120. Okay. No, despacio. Slowly. Okay. Test. Rápido. Okay. Una más. Okay. Stop the pacing. Inject. I think the position is okay. Let's go to the LV view. Here it's important to see also the right coronary artery. We have to check in advance, injectar. Okay. Here I am. Right is patent. Inject. No, the position. I think it's okay. No, I like a little bit. On the left, the contact is not okay. Vamos de vuelta para atrás, cerrar. Close it. Ponerlo a 120. Test, Silvina. Okay. Let's go. Dale, Carlos. Test. Okay. Let's go. Test. I think it's better now. Okay. Tine, test. Let's go to the other view. On the left, we don't have a good view. Check. It's borderline for a patient with not too much calcium. Volver. Let's try once again. Cerrar, Carlos. Remember, there is a patient with not too much dale test. Okay, no, it's too deep. Now, dale. Okay. Test. Okay, dale. Test. Okay, we will accept that. Vamos a la izquierda, baja un poco el marcapaso. Inyectar, Silvina. Inyectar. Okay, it's almost the same, but better. Let me pull the pigtail out. Oh, sorry, I did something wrong. I pulled the Godzilla. Let me check the coronary ostium is okay. Yes, it is okay. Let me pull the guidance. Let's have a 120. Dale, Carlos. I will pull the wire to prevent any movement of the valve, please. Okay. No, okay. Dale ahí, dale. Dale, Carlitos. Position is okay. Okay. Perfect. Okay. Well, very complex also. Let me see what's going on here. Basta de llenarlo, que lo tenés lleno. Position is okay. Stay there, quédate ahí. So now I'm sure that both pedals are free. I centralize with my shaping wire the nose cone, and I retrieve it. So, okay, it's okay. Let me close it. Mostrame un poquito de frente. Okay. We are closing without too much overlapping the device. keeping the wire in the position. I will try now to put the sheath and the pigtail. Yes. Well, this is a very nice point to be discussed. With the self-expandable valve, the benefit is you can repositioning, you can go a little bit deeper, you can check it before final delivery. But if you are going high, like we go with the cathode view, we are risking a little bit more. The benefit of balloon expandable is the frame of the stem is shorter. The upper crown of the balloon expandable valve are higher and probably easier for coronary access, especially in young patients. So it's something that should be considered in this patient if we are probably a 60 or 70 or something like this, and for some reason you are doing TAVI instead of surgery. This is something important. But here with an 80 years old lady, I think this is not important. But anyway, it's an important question, probably an open question, not definite answer for that. Some people would also discuss about which kind of self-expandable valves, because somebody suggests that accurate neo with this second crown would push the valves out. I am not convinced about that, but it's something that some investigators suggest. Give me some contrast. Let me check if I can in a way. The right. And the second question? Wow. Indian valves are cheaper than balloon Americans balloon expandable valves, but I would say that not totally cheap. Anyways, they are more expensive than self-expandable valves. And here, as I have explained previously, remember that this health insurance, which is the retired people, Caudal, makes an annual tender. And for this year, we have to use for most of the patients balloon expandable valves. Excuse me, self-expandable valves. If you want to change, you have to justify, and it's sometimes it's difficult to justify. Sorry. I think the position is great. The right coronary artery is totally open. The guiding is up. We are not able to engage anymore. So in case we had to go, we can keep the wire as a landing zone, but we had to go from inside the valve. And we have to check the gradient, and we can put the machine on the AP view, and Dr. Mokarsel can check the echo, and we can share the echo with the audience. And I think it's a great demonstration of how much time consuming is a complex PCI in comparison with some kind of regular structural cases like TAVI, when everything goes well. We still have some gradient. Let's do 0 for both. Let me flash this. Okay. And now let me do.
Okay.
And I think we have a very nice, let's show to the audience the echo.
Yeah, so here's a long axis. Fortunately, we have no effusion at all. And Actually, we don't have any leaks either.
And there I see a quite nice circular configuration of the valve. Is that correct?
Yes, it's a rounded valve with no leaks at all. LV function is normal. We have no segmentary muscles alteration like regarding the right coronary artery that you just said. And let me check the gradients.
Okay.
Okay, so we have 7 and 3.
Okay.
Peak and mean gradient.
Mean gradient of 3,
3.
peak gradient of 7.
That's right.
Here is everything okay? No pericardial effusion?
No
Nothing
effusion at all.
Okay. Let's change with the audience, with the monitor to show the blood pressure. Oh, excellent. Here you have the curves. You can see there is no gradient, very nice diastolic and very nice aortic wave configuration with a very nice notch indentation. So it's in a way confirming what Dr. Murkalsel has described from echo point of view. I will pull the catheter out. I will do a final angio, good angio, just as a, I would say, educational point of view, not because it's necessary. I will pull then the right coronary artery wire, balloon, and everything out. Everything out. Okay, thank you. Let's take everything out. It was okay, but fortunately it was not necessary to use. And now let's do a final angio there. I think we have, will you zoom a little bit? Yeah, perfect. Let me show a ventricle a little bit. Okay, perfect. So Carlos is going to check. Check. Very nice view. We can do also on the left, so we can check something that we haven't commented, which is the cusp alignment. Let's go to the. So here is okay on the left view, and we will inject and we'll see once again. Sorry. Once again, we can see that the left ostium is okay. Let's play again. And the right coronary artery is okay. The ostium are okay. So I think the cusp alignment is okay. Do you agree on that? Yeah, perfect. So the left ostium is completely free from the valve post, which are, I wouldn't say perfect, but good aligned. Then we have the valve against this calcium on the sinotubular junction. As you can observe there, is a little bit compression there. Very happy not having to post-dilate because we can create some dissection there, which could be a huge problem and in a way deadly problem in some case. So without predilatation, without post-dilatation, the potential for mean conduction disturbances is quite low, although we had to, reposition in the valve 3 times. But I was not absolutely convinced about the left sinus contact, which is extremely important for preventing valve pop-up after final delivery. But at the end, we can go back with. Let's check the last injections, la previa. No, too fast. Let me check. Let me check when we were, no. Cuando estábamos liberando. there, the last. ¿Esa es la última? There. I think esa es the last. Next, here. I think the contact on the left was probably 0, but probably because there was not perfect, or we didn't take out all the parallax on the valve. This is the reason why we see the valve very low regarding the right coronary sinus, probably 3 or 4 from the non-coronary cusp, and probably at 0 or 1 on the left. But additionally, which is extremely important, the valve was on the external curvature of the aortic arc. So in this position, it's very difficult that the valve moves too much, which is totally different when the valve is on the inner curvature where the valve tries to go deep. Next. So that's why I feel a little bit more confident to release the valve there. Checking on the right and the non, the valve was at 4, 5, or 6 millimeters, so it was deeper enough to keep the position and to be, I wouldn't say sure, but almost sure that it's not going to be a valve embolization. So next. And this is the final release. So now we are going to close here. We are pull here. We show you. Of course, the case is done. So I will leave the decision to keep here in the lab or to finish to Medstream technicians. Whenever they want, they can end up the transmission. If not, we can continue. We can show you the crossover, and we can show you also how we close with one angiosyl and also one ProGlide that we have already used it. If it fails, we have to inflate the balloon and to wait, as usually. So in this patient, we have a stent. So heparin
This is
reversion.
Danny. We would like to stay with you until for another 20 minutes, if that's possible.
Okay. Thank you, Danny.
Thank you.
So, and the other comment here, which is important, is we don't revert heparinization if we don't have bleeding in patients with the recent coronary stenting, because it could be probably dangerous. We can induce stent thrombosis, and which would be a problem. So, move a little bit here. Move la camisa para allá. Okay. It's okay. Not too much. Let me see. No, because we can. I think we have too much saturation, Claudia. You have to point out here, probably. There is okay. No more. So before pulling the sheet, I had to have prepared the 6 French sheet because we are going to close first the ProGlide over the 6 French sheet, and then we are going to introduce the 8 French angiosyl. Okay, yeah, sorry. Then hold it. Okay, wait. I don't know. No, espera. Wait means esperar. We are going to introduce English classes for everybody, including me here. Probably Danny will do it, who is hearing us from the control in New York. So now we are closing. We still have bleeding. I wouldn't say too much. Release, Carlos, release. But I think the bleeding is going to be close. Hold it. With the angiosyl. It's not huge bleeding. Why combining one angiosyl and one ProGlide? Because it's cheaper, probably safer. Some colleagues here in Argentina believes that using 2 ProGlides induce vessel stenosis in some cases. My colleague, Marco Noch, where we work, frequently in Slovenia. He's also in Portorož, Slovenia. Is also using this technique. So thank you, Marco, for teaching me to use this. So here we have back blood flow. It's important not to pull too hard. Remember, you have a suture there in a huge hole. So angiosyle in same position, I open it, I pull it, Carlos fold it. We still have the possibility of revert heparinization a little bit, probably half of the doses. Démosle half of the doses, Germán. Soltar, sí. Because we still have bleeding, hold it. And we are going to use a balloon, a contralateral balloon. So give me an 8. So let me change. We still have bleeding, despite the angiosyle and the pro line. Remember that she's still under full heparinization. That's why I am going to put a balloon. And we can wait for additional 4 or 5 minutes so we can fulfill what Danny asked me to keep on live for 5 minutes. For 15 minutes, sorry. So don't, okay. Once again, we need better closure devices. Okay, mostrame. Okay. We are going to inflate there. 1, 2, 3, 4. We have quite some stenosis. Okay, so we are not going to inflate too hard. Do we have bleeding there? No. Okay, move here. I will close the angiosyle. Solta, Carlos. Okay. Okay. We'll see. I will be careful. I will close or tight again the pro line suture. We close it. We cut it. There is nothing else that we can do from here except a punction, yeah, from below in case we have bleeding and to inflate. Let's see what's going on with the. No, I don't know if it is a bubble. Will deflate. Let's see where you have bleeding there. Yeah, hold it. Revertirle un poco más, Germán. Ah, okay. So we will reset. Let's go for 3 additional minutes. And then we will keep holding the groin for an additional 3 or 4 minutes. Protamine is still ongoing, so it's not fuel. Here we have, no, it's okay. We have blood pressure from here. The pressure is perfect. Okay. Okay. Probablemente le puedo dar media más. Okay. How is our time, Danny? How much time do we still have?
You
So
can
this
take
is a
another 15
patient-
minutes if you want, or I can switch
Okay.
out if you need to.
Okay, give me an additional 5-10 minutes and then we are done.
Perfect.
This, okay. So this is the patient with the almost normal previous AKG. Now the AKG is quite similar to before. So I think it's not necessary to leave any kind of wire for pacing on the right ventricle. So this is the patient that we have to pay attention for closing the groin to be sure that it's not bleeding. The patient should be controlled in 1, 2, and 3 hours to be sure that everything is okay. We don't allow this kind of patient to move before the next day. We are not using, early mobilization on patients that are done on the afternoon, probably something that we allow for patients that we do in the morning, and everything, especially with the groin, is okay. But if not, this patient stay in the hospital until the following day. They can walk in the morning, and we check that everything is okay. And then if everything is okay at noon, they can leave the hospital. This is our regular procedure. Our pacemaker rate. Now we are analyzing. Dr. Fava, who is on my left, is analyzing our database. As I told you before, patients without previous conduction disturbances like her, the permanent pacemaker implantation rate in our center is 2% using the cast overlap view with the self-expandable valves. But patients with previous conduction disturbances, especially patients with AV block, with the right bundle branch block, or 3 fascicular block, these patients have between 20 and 25%. It's extremely high in comparison with the so-called normal patients according to this definition. This is important for, deciding what we are keep holding a little bit for 1 or 2 minutes, additional minutes. So I think it's important, for discharging patients or handle the patients or prediction, which can be the evolution of these kind of patients. So after Kemal Gada's visit here in our hospital, we changed our practice in 1999, and there was a dramatic drop of the permanent pacemaker implantation rate for self-expandable valve. And then after our publication, Medtronic changed the instruction for use of the valve. I don't say because us, if not because the technique, which was introduced almost in all centers in Latin America. So maybe, Carlos, you can release, we can check. Maybe there should need an additional compression. We have there something, probably is the angioseal device there that we are observing, but there is not flow limiting. We can, there's bleeding?
No.
No.
No, sí.
Okay, let's go to
Sí,
the
sí,
right
ahí va,
view.
un poquito.
So
A little bit.
now there's only an oozing release. So we will have still to compress for a while. There's some bleeding there. So we have to inflate the balloon, revert the whole, okay. Inflate again. And we have to revert completely the heparinization. And yeah, and then to compress probably for 15 or 20 minutes like a normal femoral punction, because this is the bleeding we have. This is not huge bleeding. Actually, we don't have bleeding outside. This is another point, because I always use contralateral access, because this is a patient that if you leave it like this, because there was not bleeding here, only minimal oozing, you are going to be called in 1 or 2 hours that the patient is discompensated with a retroperitoneal bleeding or something like this.